Thank you for joining us for the first episode of Masters Spoke Out. I'm joined today by Mr. Assam Osman, Mr. Alok Tiwari, and Dr. Abdur Rabi. And we're going to be talking today about the decision of open repair versus EVAR for abdominal aortic aneurysms. I'd like to start by asking, what is your preferred modality of treatment if the patient is suitable for both open repair and endovascular? Mr. Osman?
Thank you for giving me the opportunity to join you today on this esteemed panel. I am pretty old-fashioned, so I think if they're suitable for both and fit for both, I would almost always do an open surgical repair. And the reason that is, I think it's more durable. Once the patient gets through the operation, the need for further intervention is much, much lower.
Mr. Tiwari, would you agree?
Yeah, I think so. I have a fixed set of criteria. So if you're a young patient and you take a wild guess, are they going to live 5-10 years, and they're suitable and they had a good anesthetic assessment saying that they're fit for an open, I would always go for an open.
Okay. Dr. Abdulhab?
My personal opinion about whether you go for EVAR or open, I think it depends on patient fitness for surgery. If they are fit, regardless the age, sometimes you are young age, but physiologically you are not fit enough, then EVAR option for those medically unfit is good option. For fit patient, open repair will be ideal, especially in our culture and the problem with long-term follow-up is not as in developed country. So open procedure will be optimal if they are fit for surgery. If not fit, then EVAR or endovascular modality will be the other option.
Perfect. So I think there's an agreement among the whole panel that once a patient's found fit for an open repair, then that would be the better option in the long term. But are there any age limits that you would consider? Is a patient ever too young for an EVAR or too old for an open repair? Mr. Osman?
Yeah, I mean, I think, no, I presume we're talking in an elective setting.
In an elective
setting here, yeah. I think that chronological age is a different thing from physiological age. And I've done aortic surgery on nonagenarians who are fit. I think if you get to 90, you're probably fitter than an 80-year-old, and your life expectancy is probably longer. I think on the reverse side, and this is an important issue, especially in countries that screen for abdominal aortic aneurysms, when you're identifying relatively young 64, 65-year-old men who are otherwise fit, I think their life expectancy is such that there must be an ethical need to offer them the longest durable treatment. And I would frown upon an EVAR in a fit 64-year-old. So I look at the screening population as a population where I'd expect the majority to be open. Unfortunately, that's not the case in the countries that are doing a lot of screening. But the reasons for that we can talk about for days. Yeah. But I'll never use age to decide whether a patient is denied treatment or offered treatment. I think it's about their physiology, how fit they are.
Okay. Mr. Tiwari?
Yeah, I would echo the same sentiment. However, I think anyone over 80, I start getting a bit nervous when we start thinking about open aneurysm. Not because of anything else, is 80-year-olds start behaving like an 80-year-old when things start going wrong. So an open aneurysm, if it's a straightforward infrarenal, long neck, you can stick a graft in and you know that's all going to go fine. Okay. But when something goes wrong, I've noticed that 80-year-olds don't behave as well as someone who's younger and fitter.
In terms of reserve, you mean?
Yeah, it's as someone said, a 90-year-old will behave like a 90-year-old when something goes wrong. And I know this because one of my esteemed colleagues in another hospital did something similar, and who was the fittest 90-year-old ever. And they behaved very badly post-operatively and succumbed to their disease. So this is despite an adequate assessment and everything. So yeah, 65 to 75, very happy to do an open, start getting a little bit more nervous. And I think also in the UK, we're very outcome driven. All our results are published. And because we're doing less and less open aneurysms, you can't really afford to make any mistakes on choosing the right patient.
Dr. Maghrabi?
It is a very good idea to have more than one treatment modality, because nowadays patients, they are exposed to the social media and the internet, and they are more educated than before. And the aging population is getting older and older. And I think patient choices will be accounted here also. Some of them, they are young, fit, and they would like to go for EVAR. So you have to take patient choice in their treatment. But me personally, I'll try to convince young at the age of 65, if they are physiologically fit, for open repair.
Okay. Now, in terms of pre-assessment for the patient to reach that decision, whether they are fit enough or not, do you have a specific protocol that you follow for all patients, or is the fitness from the end of the bed sort of an important factor? Mr. Tewari, I'll start with you this time.
So we use physiological testing for anyone with an open aneurysm. So before our hospitals merged, everyone had an anesthetic assessment, everyone had an echocardiogram, everyone would have lung function tests. And we moved to another unit where the protocol is different, that they all get CPEX and an anesthetic assessment. We decide based on that now. So I think the end of the bed test it's good. It's not great. I think you need some kind of physiological assessment. I think what you need is an experienced vascular anaesthetist also to help you in the decision making.
Dr. Maghrabi?
End of bed test is for me is a reliable test. Even the investigation sometimes is very good, and sometimes it can mislead you. And I consider patient going up flights of 2 stairs is enough to be fit for general anesthesia.
Okay. Mr. Osman?
Yeah, no, I mean, I agree with that. I think the assessment starts in the outpatient, and I mean, we use the aneurysm QIP, sort of green, amber, red, history, exercise tolerance, etc. And then from those, we filter out the ones that need more advanced physiological testing. I think CPEX is probably the best way of assessing their fitness, and to answer your question, how they're going to behave when they are not, if they have complications in terms of cardiac fitness. So CPEX, their anaerobic threshold, their VO2 max, etc., is a useful tool, and it's got some evidence behind it. Echocardiography, I think, is valuable only in the sense, for me, in predicting if they do have a major adverse cardiovascular event afterwards, are they likely to survive it? And what's a left ventricular reserve like? If you're starting with a very low left ventricular function and they do have a problem, then they're not likely to get through it. And those are the ones who you might want to go down the route of less surgical stress in the first 30 days, EVAR, as opposed to, yes, they've got good reserves. But that's essentially it. I don't think there's any role for cardiac revascularization except in a very select few prior to intervention, unless they have active coronary artery disease. Even smaller group might be for joint or combined coronary and aortic surgery. I've done a few of those in my career with good outcomes in somebody who's got very unstable angina, got a very big aneurysm. So yeah, I mean, I think most of us would do some form of testing. How accurate it is difficult to really gauge. And I think somebody who's fit for me may be unfit for Alec or unfit for Abdul Wahab. And that's, as a team, that is really important. Your whole team, it's just about the surgeon. The surgeon is one aspect of it. The anaesthetist is another. The ICU is another. And the whole team can get a feel for what they think they can get through and what they think they can't. And it should always involve everybody in that decision-making process.
Okay.
I mean, the only thing I would add from that is if the patient's already decided they want an EVAR and it's a straightforward infrarenal EVAR, I wouldn't do much physiological testing for them.
Fair enough. Yeah.
It's only for the opens that I would like some objective evidence. And we've been doing it, and Mr. Osman and I worked in the same unit, and we've been doing EVARs with very little, apart from an anaesthetic assessment, for a long time, with very good outcomes.
Okay. Now, that was mainly in the setting of a sort of infrarenal aneurysm, which is suitable for both. Do you think comparing a complex EVAR to an open juxtarenal repair is the open repair still that much heavier or a bigger hit than a complex EVAR?
Yeah.
Juxtarenal EVAR, juxtarenal aneurysm, depends what you mean by a juxtarenal. So people define it that you need a suprarenal clamp, but actually a lot of us have found that you can probably pull the aneurysm and do either an intrarenal clamp or an infrarenal clamp, and you can get away with it. I think if you're doing a suprarenal clamp, then your morbidity is going to be a little bit higher, and in those cases, depending on the patient's physiology, whether a two-vessel fenestrated EVAR is not a bad option in someone who's doing this quite regularly. And we do this quite regularly, not me personally. And most patients are doing it percutaneously, gone home in a day or two. You're not going to get that with an open juxtarenal, unfortunately.
Dr. Abdullah?
Yeah, I mean, if it is involving renal arteries, EVAR has made the breakthrough in the treatment of abdominal aortic aneurysm. And the outcome is much better than open because you don't compromise the kidney function of these patients. And there is evidence that's good results in complex EVAR. However, the age here, we have to select the age is not an issue because the complexity of the aneurysm is more than the chronological age or physiological fitness of the patient.
So you would follow the same criteria for picking you?
Yeah. So basically it is from patient to patient, case by case selection and understanding of the anatomy of the aneurysm and the complexity. And then you choose the right modality and you have to discuss that with the patient himself and see what they like to have with your guidance, basically.
Mr. Osman?
Yeah, no, see, I think this is where we get a bit confused here. I think people often underestimate the outcomes of complex endovascular procedures and think that it carries the same advantage as an EVAR, a straightforward EVAR does over an open aneurysm. I think if you're honest and look at the data with clear eyes, you'll find that, we're talking about 6-7% mortality rates at 30 days, which are and major complication rates, which are not far off the open repair. So for me, there are really two groups of complex aortic aneurysms. There are those who are old and frail, who have a limited life expectancy, in whom I think a complex EVAR is clearly going to give them a better chance. But I don't expect them to live beyond 5-6 years. I think in younger patients, I don't feel there is a place, young, fit patients with good life expectancy, for a complex endovascular procedure, except within the context of a clinical trial, to answer that very question. People have shown, even if they get through the initial problem, the hit of the surgery, we're seeing long-term renal function deterioration. We're seeing, obviously, the myriad of graft problems requiring re-intervention in a high proportion of patients. And it becomes a self-fulfilling prophecy. If you are not doing enough open aortic surgery for the straightforward ones, you become more and more risk averse to the more complex open ones. So by default, you're doing less complex open aortas and you have poorer outcomes and you tend to lean towards endovascular. So that's why I think we need a recalibration, really. And that's why it's so important to keep doing a number of open aortic aneurysms. We have a generation of vascular surgeons who are more comfortable with the wire than they are with the knife. And therefore, patients, I think, are being, in my mind, led down a route which is more comfortable for the surgeon than it may necessarily be for the patient in the medium and long term.
Okay. And to sort
Don't
of
call me old-fashioned.
sort of to end this session, I think the last topic is the less common situations, sort of aortoenteric fistulas, mycotic aneurysms, connective tissue diseases. Would you only consider EVAR as bridging therapy in these cases, or is there a role for EVAR as a primary definitive treatment? And I'll start with Dr. Abdulwahab.
I mean, EVAR with the complication of EVAR or open is aortoenteric fistula. By bridging with another EVAR, I think it carries also the risk of making the definitive procedure more difficult and more complex. So if you go back to what we said those who had EVAR, they are high risk for surgery. So now we're coming to the stage, high risk surgery becoming more complex surgery. And you start thinking, yeah, this is life-saving procedure. And they come through that procedure sometimes okay, and sometimes they don't. So we are adding, by putting bridging, we are adding to the complexity of the procedure if we are going to open, which we have to. So me personally, I see bridging, you make your life more difficult. Try to put a balloon, yeah, and do the open procedure at the same time, and good luck.
So you go straight for the definitive procedure.
Yes.
Mr. Osman?
Yeah, I mean, I think that the different conditions, right? Mycotic aneurysms, and certainly in my current practice, we see a lot of mycotic aneurysms. It depends on where it is. I think if you're talking about a thoracic, mycotic aneurysm, bridging stenting is very helpful because they're often very ill if they're about to rupture or ruptured, and going in that scenario, opening their chest, suprarenal clamps, supraceliac clamps is tricky. So a bridging stent there can get you out of jail, and then you need to follow up. I mean, sometimes you can bridge for quite a long time, for months or even years. Aortoenteric fistulas, for me, again, if they are de novo or in the presence of a graft. So if they are de novo with a mycotic aneurysm, and the patient is, reasonably stable. So for me, that is, they have a blood pressure of over 70, they're perfusing their brain, and they can talk to you. I still go open, but that's because I'm comfortable doing, and I've done a lot of open aortic surgery. I think if you've got an infected graft, then explantation, again, if it's EVAR versus open, if it's an EVAR graft, explantation, if you have to do a suprarenal clamp, carries a high mortality, 25-30%. The clamp above the renals is a game changer. But there are ways where you can clamp below the renals, leave cuff of the EVAR in. But if you think, I need to buy myself a few days, then it's not an unreasonable thing to bridge.
Mr. Tawari?
I agree. I think location is the key.
Yeah.
Depending if it's a straightforward young patient with an infrarenal mycotic aneurysm. What I know is if you don't do a definitive repair now, the chances are you're never going to do it. Because when the patient's well and you say, right, I'm going to go and do an elective operation with whatever mortality you decide to quote, I'm going to take your deep veins out or homograft wherever you can get it, it's not going to happen. So I think it should be used as a bridging therapy, but it's not used as a bridging therapy, and that's the reality of life.
Okay, so this brings us to the end of this session of Masters Spoke Out. Thank you very much for joining us, and thank you to our esteemed panel.
Thank you.
Thank you very much.
Thank you for having us.
Thank you.
Bye-bye.